This is a demonstration for the use of the Tereboot positioning device for ultrasound-guided sciatic popliteal fossa blocks for patients in the supine position. Now your patient's already going to be supine, so you don't have to do any special positioning or maneuvering, and that's what's so nice about this technique. It makes it convenient, efficient, and ultimately most comfortable for the patient. Now the device itself only weighs about 9 pounds, so it's very portable. It can easily be transferred by holding on to the handles on either side. It's constructed out of all metal. That makes it extremely durable and stable. Now you want to put the device directly on the patient's bed with the adjustable feet on the lateral side. When you put the patient's leg in the device, you want to make sure you leave plenty of room to work in the posterior fossa. At this point, you can make a couple of adjustments if need be. One is to the height. The vertical shaft has a pin that can be removed and the height adjusted. This will change the angle of the leg to your preferred position. It ensures that you have plenty of space to work, and it also can maximize patient comfort. The other adjustment is tilting medially. Some patients, particularly after they've had sedation, can have an extreme amount of external rotation. That can distort the anatomy. So rather than having someone hold the leg throughout the whole procedure or putting a bump underneath the patient's hip, you can simply rotate the feet underneath the platform, which tilts the leg in the positioner. That will offset the external rotation and restore the relative anatomy. Now it's not needed in this case, as it is in most cases. So I'm going to put this back and stay in a neutral position. Now the first thing I recommend doing when performing this block is to determine the level of the bifurcation of the sciatic nerve. I'm going to start distally in the fossa, just medial to the biceps femoris. I'm going to locate the tibial nerve, follow it proximally to just distal to the bifurcation. Now I'm going to mark a point at that level in between the vastus lateralis anteriorly and the biceps femoris posteriorly. Now these are standard landmarks that are used for neurostimulator techniques. I can then put my probe onto the handle. It was made to double as a support for the probe, so it's always easy to get to. Now I'm not actually going to do the block because my patient is actually a generous volunteer, but I would prep the patient at this point. And then when I drape the patient, I want to make sure I keep the drape out of the posterior fossa so it's not in the way of the ultrasound probe. Now at this point, I have a couple options in terms of placing and guiding the needle. One is to follow the needle in plane all the way from the surface of the skin to the nerve. Alternatively, I can place the needle in close approximation to the nerve, find a fixed needle, and then make small adjustments under ultrasound guidance. I actually prefer that latter technique because I find it more efficient. If you would choose to do that, how I would recommend doing that is you want to enter and advance the needle parallel to the bed to a depth of about 1.5 to 2 centimeters, less than half of the width of the patient's leg at that level. Now this should get the tip of the needle close enough to the nerve that you can see it in the same ultrasound frame, but not close enough to contact it. Now you can actually determine that depth by superimposing the needle above the thigh, but after you've done a few, it's really easy to estimate. So once I have the needle in position, I can take one hand to manipulate the ultrasound. Now it's now behind the drape, which means I don't need to put an ultrasound cover on, which again makes it much nicer and a more convenient technique. What I do is I start distally, again, travel proximally until I see the needle. Usually it's easily identifiable. At that point, I can make small adjustments to get my needle tip exactly where I want it to be so I can deposit the local anesthetic. Now at this point, I'll often leave the patient's leg in the positioner if I want to do a saphenous nerve field block to achieve complete anesthesia or analgesia to the foot and ankle. That can be done either proximally or more distally by the malleolus. In addition to being ideal for popliteal fossa blocks, the Tereboot can be used to perform ankle blocks. By just moving up the positioner slightly, it exposes the entire ankle circumferentially while supporting and stabilizing the leg. Now when your procedure is complete, you can just remove Tereboot. The patient is supine. You've never had to reposition the patient. You can take out the disposable cushion, and you're ready to go.